Good morning. Aloha. I used to live here, and so it has a real special meaning, and I can really say it correctly. So let's say it again. Aloha. Aloha. All right. This is an implementation meeting. You say, oh, thank God there is. How in the world are we going to get this done? So that's what this session is about. This group is through the ICU Liberation. Those members of the ICU Liberation, if you'll please stand, the committee, if you'll stand and be recognized. Congratulations. I'd like to let you know that hot off the presses, Marianne has an article. It's on the far end over there. Feel free to pick that up. And what will happen is we'll have individual presentations, and then there will be a panel. Enjoy. Marianne.
Good morning, although it feels like it's about 4 in the afternoon, right? Thank you, Carol, for moderating and introducing, and also thanks to all of you who are not attending the sepsis lecture. It seems every year we are scheduled opposing them, and you know, the two issues that are nearest and dearest to my heart are sepsis and ICU liberation. So if you see me dart no, I'm just kidding. I'm going to be here the whole time. So if you're looking at your program, you'll notice that the topics are in order, but we elected kind of at the last minute to switch the presenters because we felt that we would more aptly address the content as it is. So my goal for my 20 minutes is to share with you basically how we started the collaborative, the things that we did, how we worked with the collaborative members, what we learned, what they learned, and then I'll leave some of the nuts and bolts to my esteemed colleagues, Michele Balas, Brenda Pun, and Wes Ely. So I have no affiliation with industry. I do receive grant funds from the Gordon Benny Moore Foundation. So before I talk about what the collaborative was and what we did, I just want to take a minute to reflect on ICU Liberation, and I hope that most of you were able to hear Wes's plenary just now. He gave a really heartfelt, spirited talk around how we got where we were and why we should be doing this work. So when we talk about ICU Liberation, and the way the name actually evolved was at Sutter Health at first, where we talked about liberation from the ventilator, but we also realized we were liberating from delirium and liberating from pain, liberating from agitation and liberating from oversedation, liberating from the bed. And so what better name would we have than ICU Liberation? And many of our patients leave our ICUs vibrant and functional, like this woman appears. But many of them don't. And our patients talk about being freed from a cage or feeling like they're being held underwater. And when they leave us, again, some of them emerge okay, but some of them not. And of course, there are those patients, as Wes described, that leave us and change planes. But providing the bundle even to those patients at the end of their lives, is particularly certain bundle elements for them, is also very important. So we'll talk in a minute about every patient every day. But unfortunately, as Wes described, some of our patients leave us in this post-ICU discharge cage. And many of the causative factors around that is the evidence that we know now about how many of our patients with the high incidence of ICU delirium is, and the post-discharge sequelae, the in-hospital sequelae, and the independent risk factors that delirium poses, but also the post-discharge sequelae. Many of our patients leave with post-traumatic stress disorder, and this is not because they experienced a difficult ICU stay and from things that we would consider normal, such as ventilation and bed rest and whatnot, but because of things that in their delirious state they perceive as being real. So those delusions that they have, and patients will tell me they're not like dreams. I don't remember what I dream. These are actual nightmares and delusions that don't leave me. And just like with other PTSD patients, they reoccur, and they continue to experience them. and they prevent patients from going back to their jobs and their lives as they know them. The devastating effect that delirium has on brain function, and also immobility, causing post-discharge weakness and inability to return to the state prior to admission. One of the most, I think, devastating effects of delirium is the loss patients have of their executive function. And if you look at each one of these domains, you'll see that this pretty much governs most of what we do in our lives, particularly those of us that are very vibrant professionals. And in Wes's story, the ICU nurse who couldn't even return to work, this is very common, and this is happening to thousands of patients every month in our hospitals, in the United States at least, and of course abroad as well. So again, my goal today is to share our collaborative work with you, to discuss the methodology that we used in the effort that we undertook, and importantly, to describe some of the tools that can be used when you want to do this work to measure and drive your success. So of course, we are governed by the Society of Critical Care Medicine's Pain, Agitation, and Delirium. The most recent iteration provided by lead author Dr. Julie Barr with collaboration of many. These guidelines were published just at the time as I was starting my work back in late 2013, and I told Julie I thought I had died and gone to heaven because she provided a platform, an evidence-based platform for me to do the work that I needed to do. In its current iteration, you'll see here the ABCDEF bundle, where A is assess, prevent, and manage pain, B is both spontaneous awakening trial and spontaneous breathing trial, C is choice of analgesia and sedation, delirium, D, delirium, assess, prevent, and manage, E, early mobility and exercise, and F, family engagement and empowerment. So I don't know if any one of those bundle elements would be considered revolutionary. I think perhaps for some, allowing patients to be awake and responsive in the ICU may be revolutionary, or getting a critically ill patient out of bed and walking them down the hallway may seem revolutionary. But I have found in my own work, and others tell me, that the revolution that's needed is what people describe to me as, well, we need a complete culture change in my unit. And I say, please don't use that C word. Because when you come to people and you say, we want to change your culture because you're doing it wrong, I mean, what kind of buy-in do you have? What kind of resistance will you encounter? I say, let's change certain behaviors. And Wes aptly called them rituals, because we just follow these things by rote almost. Let's change behaviors of deeply sedating patients and tying them down in bed and making their family members leave when something that we may presume is traumatic is happening and we don't want to be observed providing care. So what's revolutionary is us changing our behaviors and our beliefs, often driven by myths around what's really going on with the patient, and understanding that by letting patients be awake, interactive with their families and caregivers, and get up and walk and look out a window actually saves their life, both while in the ICU and after. So the ICU Liberation Collaborative was a national campaign. It was driven by data. Process improvement needs to be driven by data, I believe. It was specifically aimed at implementation of the PAD guidelines through the platform, the evidence-based clinical platform of the ABCDEF bundle. Our goal was to formalize dissemination and implementation of the strategies that are named in the bundle. That's easy. To standardize and track key performance measures, and to help teams overcome barriers to effectively incorporate these clinical elements into their daily care. So how we started was with an interprofessional panel of 23 ICU clinicians who had specialties in the areas, in the domains of ABCDEF bundle, either individually or combined, and also quality improvement efforts. And we reached consensus on how the bundle should be defined, how it should be implemented, and how it should be measured in daily practice. When we talk about the gestalt of improvement, really we need to talk about what is the process, what are the steps we take, what methodologies have been proven to be successful, particularly for this bundle, and were we compliant? We all say we want to do it and we think we're doing it, but how much are we actually doing? And I think Wes gave us some numbers about that just a minute ago. And more importantly, the performance of the bundle elements. We'll talk a little bit more about that, but did the patient actually get the bundle element? And so our collaborative teams were comprised of 69 adult and 9 pediatric units. We had hospitals from academic centers, Veterans Affairs, and community hospitals from 29 states across the country, including Puerto Rico. The retention of the teams in the collaborative remained high over the lifetime of the collaborative. As teams started, we actually asked for some commitments. We wanted teams to fill out pre- and post-collaborative surveys. We wanted to identify core team members that would participate in the work. We wanted certain implementation strategies, and we required teams to collect and submit data so that we could make sure that we were moving things in the right direction. The core interprofessional team needed to be comprised of at least one provider and one RN, and additionally one or two other members from an interdisciplinary team. We asked teams to complete and submit two types of surveys. One was an interprofessional ICU team survey so that we and they could learn who comprises their team, how they evaluate the health of their team and their ability to cooperate and collaborate and share decision-making to implement this work, what tools the team could use to facilitate implementing the bundle in their daily work, and how well they communicated. We also asked for some administrative data so that we could understand the type of units with which we were working. So ICU nurse managers and medical directors provided information about the unit, the type, ICU, a MICU, SICU, whatever type it was, and how many beds and so forth, what their operational environment was like. Many of these data were used both to help the teams and also to help us in our future data analysis. We asked patients then to submit data we asked sites to submit data about patients. Each day, sites were collecting data on individual patient bundle implementation. The ABCDEF bundle daily compliance form was used for each patient. And also, we had a demographic and discharge form which provided important information about patient and family-centered outcomes, certain variables that may affect bundle compliance, and important prognostic indicators such as demographics, diagnoses, and comorbidities, for instance. For the patient-level data, because we wanted to do a before and after study, we asked for the submission of baseline data, which consisted of the first 5 patients in each of the months from January through June of 2015, for a total of 30 baseline patients per each site. For prospective data, we asked originally that the first 30 patients per month be abstracted. This created quite a data burden. We received information from our sites that they were struggling to comply with this because, quite honestly, the amount of data that we were asking for was significantly robust. And so very quickly we reduced the requirement down to the first 15 patients per month because unlike something like the sepsis bundle, this bundle is every patient every day. So they were collecting these bundle compliance and other data every single day, up to 7 days for these patients or until death or transfer out of the ICU or a change in status to non-ICU status. So I think one of the things I'm most proud of, and we worked with Wes and also Michele Balas and Brenda Pun, I think one of the things I'm most proud of as a product of this collaborative was our decision and collaboration around and production of operational definitions of what it meant to actually do A and do B and do C. So we looked at the PAD recommended valid and reliable tools for the assessment of patients' level of arousal, for instance, and we said please RAS or SAS. We looked at the PAD recommended tools for delirium assessment, CAM-ICU or ICDSC. We gave some parameters around what it meant to do an SBT and how you knew you were doing one and whether it really counted or not. And then what were the parameters around early mobility? What did it mean? Was it enough to do passive range of motion in the bed? No. Our goal was at least to have the patient sitting with legs dangling, and best care is to have the patient leave the bed. Where's Heidi? She's not standing up screaming, yes, that's what I am. And then more importantly, because this was a relatively newer element, although we have a lot of data around the involvement of patients' families in the ICU, we really needed to have some information to guide sites about what it meant to not just provide information to families and not just engage them, because I think many of us do that, but what it really meant to empower them to be part of the care team and take part in care planning and healthcare decisions. So this is an example of a patient-level data definition, one for A, which is the assess, prevent, and manage pain. Did you use did you use the NRS, which is PAD recommended? And if the patient was unable to self-report, did you use one of the two PAD recommended nonverbal scales, either the Critical Care Pain Observation Tool, CPOT, or the Behavioral Pain Scale, BPS? And then we asked other information that was not necessarily, may or may not have necessarily been linked to compliance, but it's also going to give us a deeper dive into some information around how things actually function in ICUs. And when my colleagues author the next paper, in which we'll see some data that came out of the collaborative, these type of data will be able give us the opportunity to provide you with even more information than simply bundle compliance. For letter C, the choice of sedation and analgesia, we ask, was there a documented sedation target level? And if so, how many of those assessments that you made during the day were outside of that level? Again, compliance would be that we used a PAD recommended assessment tool to assess for the patient's level of responsiveness. How often did we do that? How often did we miss the mark? And do we even have a target or a goal to shoot for? Very important. So another thing that I wish I would have done in my paper that I didn't, that I think we really focused on in this work, is to make a distinction between bundle compliance and bundle element performance. This is really key, and let me give you an example. My teams could be compliant if they performed a spontaneous awakening trial safety screen. So if the patient met a certain FiO2 criterion, or if the patient, was at a certain level of PEEP below 12, then the team was able to move forward with providing the SBT. If the patient failed that safety screen, the team was compliant with the bundle element, but the patient never received the intervention. And so one of the things we really want to be clear about is, yes, you can be compliant with the bundle, but if your safety screen, for instance, is too strict, then the patient's never going to get the SBT. So what we want to know is, how compliant was your team with following your rubric of what the bundle looks like? And then how many of the bundle elements did your patient actually receive? And again, I'm looking forward to the very robust analysis that my colleagues will share with us probably this time next year. So what we did during the collaborative is 5 in-person meetings. We had 3 collaborative sites, West, East, and Midwest. Those groups met together at 5 in-person meetings. We had monthly co-learning calls. We had database training sessions on the REDCap database where teams submitted their data that they had collected. We had a very active and valuable e-community listserv, and we had select in-person site visits from some of our faculty. We provided a roadmap how to implement the PAD through the ABCDEF bundle, and of course, always emphasizing why it's important to do so. And our end goals were the what is the bundle? Some folks weren't even really clear about what the bundle elements were. How to implement that, the ICU process, the process in your ICU of how to implement that. And then how to use templates that we derived during the lifetime of our collaborative so that other folks who weren't in the collaborative could copy what we had done to move more towards success. So we know that ABCDEF bundle data already published shows good results. We should do this. We wanted a plan that yielded good team dynamics that would support good patient outcomes through implementation of the bundle. We know that every unit has its own culture and it's different. It depends on your unit's baseline practice. Some of you are so close and just need to improve. Some of you are just beginning. We feel like the work that we've done and the tools we'll be able to share with you will help both of those types of teams. So in conclusion, considering the hundreds of investigations from all around the world specific to these bundle elements and these elements as they relate to patient care, it would be expected that consolidating them into the bundle and using these tools at the bedside would be imperative to accomplish the process of the implementation of the ABCDEF bundle, and that's what our collaborative has been about. Thank you.
Thank you so much for that. Now, my job is to first find my slides. Oh, there it goes. Wonderful. So I'm Brenda Pun, and today my challenge is to share with you a little bit about why we thought teamwork was so important that it had to be a fundamental part of the foundation of this collaborative and therefore the implementation of the ABCDEF bundle into practice in your units. And I was warned this could happen. They're backwards. So that's the end of my talk. Thank you very much. Let's see, this way. That's my next to last slide. Yep, you did. She did it yesterday, so I'm going to talk while she gets them organized. So we just had to go backwards through all of them, or? There we go. This one. This one. Got it. Teamwork matters. This is an example right here. No disclosures. Thankfully, we can zoom over that. So we started with a mission statement with this collaborative that our goal, the goal of the whole collaborative collectively, was to create lean, sustainable, and highly functioning ICU interprofessional teams that partner with patients and families, so broadening the definition of team there, to create a safe and comfortable environment through implementing the PAD guidelines and through the utilization of the A to F bundle. And so what I wanted to point out here is that fundamental in this is the idea that we need to work on teamwork. So why do we need to work on teamwork? This has already been alluded to. I just want to give another shout out to this paper by Mary Ann Barnes-Daly, and that it's at base in this paper, their implementation project involved a significant interprofessional teamwork teaching sessions with all of the teams that were part of them and building that culture of teamwork within those units. So I love the Swiss cheese model, and so this is based on the aviation industry, and is one of my favorite things that I've learned over the past few years. And the idea behind this is that we've got to all be system thinkers. We can't be point of care only thinkers. We can't just be thinking about the delivery of the drug, but we've got to think about all the places that drug goes and all the hands and the minds and the clicks and the people and the handoffs that happen prior to the delivery of that drug. And so when we think about the implementation of this bundle, we really need to be system thinkers. And we need to think about not just the tip of this arrow, but all the layers of our system that have to be in the right place and all the holes that might need to be plugged in order to decrease the opportunity that we would be doing harm to our patients by withholding some of these interventions to them. And so I think in the safety world, we've talked about the Swiss cheese model a lot, and idea that we want to prevent an error. And what I want us to broaden out our definitions here is that we want to create it so that we're not preventing them from getting these things that are going to help them. So the results of an unhealthy work environment or a lack of teamwork we see this in so many different areas, and the impact is far-reaching. And burnout, that's a big topic that we've even heard here at this conference, and a big part of the future of where we're going in this next year. And dissatisfaction among our staff, high turnover, that significantly affects us, and it affects our patient care. Increased costs, decrease in the perception that we're able to give good care, which decreases job satisfaction, leads to more burnout, and then actual decrease in patient outcomes, the decrease in providing patient quality care. And so this bundle aligns these processes that we've already mentioned, the different components or the bundle elements, and the idea of bundling them aligns that, but it also aligns our people that are involved. And so if you think of each element of the bundle, it really challenges us that multiple members of our healthcare team need to be working together in order for these handoffs and this coordination of the elements of this bundle to happen effectively and efficiently to yield the results that we really want and are possible for our patients. So as part of this collaborative, and what I would encourage you to do as part of the work that you are doing in your units, is to think about how can you, as your first step, assess the healthiness of your unit. And assessing teamwork, this is what we did. was we started with 2 surveys, and I'll talk about one and then the other, and I'll share the baseline results of the whole collaborative in the midst of that. Is we wanted to look at teamwork, and so this is a scale, the Assessment of Interprofessional Team Collaboration Scale, looks at 3 domains of teamwork: coordination, cooperation, and partnership. And the role that they play in evaluating your team and how the individual professionals, as well as the team collectively, perceive your team's health in those 3 areas. So let's look at coordination, just so that we all have these definitions of what that means. So this is the ability to work together to achieve a mutual goal. And it involves interlocking elements. And the example that I use most often for this is it's really difficult to mobilize a sedated patient. So if we're not having good coordination among the team members in our unit and among their actions and ability to communicate that with one another, we're not going to be able to have progressive early mobility in our patients who are still deeply sedated. And if the timing is wrong or the handoffs in the communication are off, we won't do well in coordination. Cooperation is working together. So each person's skills, their knowledge, their talents, their framework from which they come professionally are valued and sought out. So we seek each other's opinions and expert consultation on our patients. So the example of this would be discussing plans for the day in rounds and dividing up the workload. And also dividing up the workload of decision making. What do you think is the best thing to do from your expert stance as the social worker? Where do you think that we should be thinking about? What do you think we should be thinking about for this patient? And as this patient's bedside nurse who's spending most of the day, tell us what you think would be the best move for this patient. And then partnership is having shared decision making, where 2 or more people work together on decisions to come to an agreement. And that includes expanding this team to the patient and their family members. And this may involve some negotiation and talking with one another through disagreements on what the best next step might be. And an example of this is family meetings to talk about end-of-life care or palliative care, or about what the next steps are going to be for moving this patient out of the ICU, involving family members in that to have shared decision-making about what the patient's preferences and what the needs are of the family and the patient, but as well as the other teammates. What's possible for us to do with this patient today, given our demands on us as professionals and what the other things are going on in the unit? What can we do together with this patient today? And so these are the baseline results way back over a year ago when all of our collaborative sites sent out this survey to their interprofessional team members, and they were encouraged to send it to all team members. And this is these in the 3 areas. Again, this is aggregate report of the over 3,500 participants in the survey. And if you look at this, a couple things I would point out in the 3 categories is that they were not bad scores, and they weren't the best scores. So we had each participating unit got their individual results, and they also saw the group results, and they also saw themselves compared to regional peers. And what they were able to do is take this back and say, here's our benchmark. Either cheerlead, look how healthy we are to begin with, or wow, we have some room for improvement in one of these areas. And if we were just pretending and looking at this collaborative or these aggregate data, we would say, it seems that we're weakest in the area of coordination. So what are some things that we can do to build our coordination and strengthen that and make our ability to coordinate stronger? And what discipline really thought we were weakest in coordination, and how can we improve that and build upon that? And so what we did is provide them with tools and strategies that address each one of these areas. So they could say, we're weakest in this area, what can we do to improve on that? Or we want to see ourselves improve in all these areas. So these are just pulling out the questions that scored the lowest overall, and I want to give you a flavor of that, is that these overall for the whole collaborative were the lowest scoring questions. Is that we select a leader of our team together, We share power with one another. We establish deadlines for steps and outcome markers in regards to the patient. We consider alternative approaches to achieve the goals. And we agree when care decisions are made, the leader strives to obtain consensus on plan processes from all parties. And so knowing the questions that your group scores weakest in, really enables you to say, wow, I didn't realize my other teammates felt that way. Or I didn't realize that we collectively, we're leaving out somebody. And often if you're leaving out somebody, and you don't know who you're leaving out, because you're not considering their input or their presence to begin with. And so it's really helpful to use an objective tool like this that helps bring those things to light, kind of as a third-party counselor, which I say every good family should have a third-party counselor that's a part of your lives to help you identify things that you don't even see because it's such a part of your day-to-day interactions. So what about that work environment? And the American Association of Critical Care Nurses has really been on the forefront of leading all of us in critical care, and I would say healthcare in general, on understanding what a healthy work environment is and the impact of a healthy work environment on ourselves and professionals, but as well as on our patients, and also highlighting the dangers of an unhealthy work environment, which we've already talked about. And here are the key elements: that it's a safe, it's healing, it's humane, it's respectful of all the participants that are involved. And the 6 domains that they have identified for a healthy work environment are skilled communication, true collaboration, effective decision-making, appropriate staffing, having the right people and the right amount of people in the positions, meaningful recognition. And this is a tricky one, because maybe the star employee of the month is great and is real meaningful for some people, but other people, it's not that big of a deal to be the employee of the month. I'd like a cash reward, right? Like some of us like to be recognized in different ways, or a handwritten note, and really helping everyone to see what are different things that fall under meaningful recognition, so we can have a diverse way that we recognize our staff, so that we can hit on all of those love languages, to use a different language, that people, how they receive recognition is really different. And then lastly, authentic leadership. So that was the healthy work environment is an 18-question survey that was a part of that initial staff survey, and these are the results from of those 6 domains. Again, if we can highlight and we can use this to hone in, we can see overall, again, we're above the 3 mark of the neutral area, so we're moving towards the healthier work environment, but we're not quite up to the 4 score. And so there's room for improvement overall in all of these units in these particular domains. But then we can identify, if we were a site participating in this, or if you do this survey, which is available to everyone on AACN's website, you're able to identify what your weakest areas are and zoom in and say, oh, meaningful recognition is where we're low. Maybe our physical therapists feel like there's no recognition for them. Or maybe no one is giving any thought to recognizing the excellent work that our respiratory therapists do. Or the nurses are being left out, or the physicians are being left out of having some type of meaningful recognition. What was really great in this survey is also you can see that the domains are similar to that coordination, cooperation, and partnership that we saw in the other survey. So it allowed us to see that they are both pointing towards some weaknesses in our group. That true collaboration showed back up in this survey as it did in the other survey. The 2 questions that scored the lowest or really stood out in the healthy work environment was that the reward and recognition system made team members feel valued. So that really identified a need to think and creatively about recognition and reward systems, and that they feel like they're able to influence what's going on in the unit. So I love this quote by Winston Churchill, and I've been watching that mini-series on Netflix, The Crown. Has anybody else watched that? Okay, if you have nothing else to do, watch that. I think it's really good. but it depicts Churchill in his latter years. And so I love this quote by Winston Churchill. And he says, "We shall not fail or falter. We shall not weaken or tire, but give us the tools and we will finish the job." And I think that's what this part of the survey and what I would encourage you all as you're embarking on this idea of implementing this big bundle into your practice is you need some tools to go along with it. Your team needs tools. And by that, we don't just mean a really great policy and procedure for how to do an SAT, but your team needs tools to coordinate, to communicate, to have that shared decision making. You need that to be a part of the fabric of your unit. So some of the tools are patient care rounds, synchronizing goals, checklists, scripts, and meaningful recognition ideas. And what I want to show you, and some of you are out there, I see sites, although you didn't stand up or raise your hand when they said who's involved in ICU Liberation. You're out there, and you may see your picture up here because I pulled a lot of, our team shared what they were doing in these different areas. We had lectures, and we had coaching calls on teamwork, and we had sites sharing with one another, hey, I did this. It worked really well in the unit. Everybody got jazzed, and it really helped us. And so here's ideas. Now, this is patient care rounds, and it's an interprofessional team. So many of the teams that worked on this collaborative, this was where they started, was realizing who's missing in our patient care rounds, and how can we make it more of an interprofessional rounds environment. And you can see this is a picture identifying each of the professions that are represented in that daily rounds that was occurring. And then we also threw out an idea to them, this idea of discovery shopping. And this, I used to be a secret shopper for my movie theater. It's an excellent gig, and it's not a scam, so I encourage it. And you get all these movie tickets, and you go there, and you have to order a popcorn, and then they have to try to upscale. You're evaluating whether they try to upsell you. And so you don't have to go undercover. I had to be undercover. I wasn't allowed to tell them that I was a secret shopper. But this is a discovery shopping. And the idea here is that you're gonna be the observer. And it's really the basis of the idea of gap analyses, which this is more familiar for some of us. You're going to just observe, be the reporter that is looking at what happens on round, how long does it take, and what does it look like for that? What did I learn? And then you're going to report back to the team. Reflections from some of these is most RNs are participating in rounds, great, and they're using our round templates. Some are still hesitant to communicate. So you're able to give report back, and your team is able to tweak what you're doing. Family-centered rounds, moving rounds into the room, that was one of the improvements that they worked on. Synchronizing goals together, so some of the teams really got materials together and had everybody sign it, or they framed things that had to do with, we're working on this bundle, and they took pictures of themselves, sometimes because we required it, but then other times because that's what they posted and cheerleaded, and then they had something to send to somebody else in the hospital for meaningful recognition. And I'm talking about the management people to say, look at our team and what we're doing. Having checklists. This is a checklist from one of our groups that specifically identified each letter of the bundle. And this is a version of that, but it was a rounding script so that the bedside nurses would have exactly the template that they were using to report from. Communication tools. I love this. This is a place that doesn't have a fancy dashboard, and they were able to work on an electronic dashboard, so they created a paper dashboard that went in the window to say, this was a part of the communication handoff of respiratory was handing off to the nurses, or the nurses were handing off to respiratory. Inviting feedback. Hey team, posted in the break room, here's how we're doing, comment here. And taking those comments and incorporating them in. Meaningful recognition, these are some other ways that we celebrated achievements, we had an online way that we also got that feedback. The medical director came and took pictures of us ambulating people and then shared that with the rest of the administrators and stuff to say how we were doing. Publishing in your local reporters or that sort of thing, eating cake, and these are bright spots. How did we do? Our team's more cohesive. This is working. And we've created some fierce advocates. And then I like to end on this, is that what surprised us most, and this was one team's quote of what surprised us in the process of this collaborative, how a little bit of improvement in the way that we organize our interventions, improve communication by speaking the same language and teamwork impacted the total number of hours that patients were on mechanical ventilation in the ICU and in the hospital. So teamwork matters. It aligns the bundle and the people. And now I'm going to pass it on to, I think, Michele Balas, who's coming up.
I have to say we have actually the greatest team. We work under one brain at this point. What one person can't do, we pass along to the next. Thank you for giving me this opportunity to speak to you. And I have the opportunity of, hold on, I guess we go backwards. I have the wonderful opportunity to share with you some of the findings from our teams. The collaborative that we've taken part in, the amount of work, dedication, excitement, and engagement that's been displayed by the people that have been participating in this collaborative was so thoroughly impressive. You guys are changing the world, maybe not immediately, but in the time to come, and I really wanted to take this opportunity from our team to thank you guys for everything that you're doing. Now, some of you may not be participating in the collaborative and may be here to learn about, okay, so I want to go back. I just heard Wes talk, and in the previous lecture, I'm going to go change the role when I get back to my place. How can I do that? Well, what I'm going to share with you is what our teams have taught us so far about how we can get some of these interventions into everyday practice effectively. Excuse me for 1 second. The backward thing is going to be challenging. So instead of focusing on the negative, which I have a tendency to do, so I rely on my team to bring me to the non-dark side, we're going to focus on some of the barriers that you could expect when you go and try to put all these things into practice. There are some very common implementation challenges that you're going to face. Electronic health record systems, the need for additional education when we're coming to all these new tools and tips and all the things that we're going to be putting into practice. Anybody here have adequate staffing ratios? Abundance of nurses, physical therapists, respiratory therapists in their unit? If so, come see me. I know there's a lot of nurses looking for new positions. But the challenges that we face in terms of staffing ratios and turnover rates. Turnover rates in terms of, in particular, our nurses moving from the bedside to advanced practice roles, always having new people coming and onboarding, it seems, with residents and fellows. Documentation. Anybody in the room enjoy how much documentation they have to do on a daily basis? No, probably not. So there are some common implementation challenges that relate to all of them. Now, I did have what the A means. If you don't know, the A in our bundle stands for Assess, Prevent, and Manage Pain. One of the things that we found consistently challenging when we learned from our sites is the use of behavioral pain scales. In fact, a lot of our sites weren't using a behavioral pain scale when they started, and if they were, it may not have been one of the PAD recommended tools. Why does that matter? Well, if you're a PhD prepared nurse, you like to think about concepts and theory. But you really want to have a tool that's measuring the phenomena that you're interested in. So it's important to use a tool that measures pain effectively. The complexity of system-wide changes in terms of assessment and documentation of pain, if you are, what we learned, or you might be a participating unit in our collaborative, but that unit is just part of a more larger health system. And if you want to change anything in your unit, you often have to change things within the entire health system. So how very difficult that process can be. And again, the reliability. Are the people that are actually administering the tools doing that in the right and proper way and getting the results that they are supposed to be getting? I didn't say greetings from the state of Ohio. Greetings from the state of Ohio. A couple more challenges in particular with A. We found that most people report, and isn't this true, it is much easier to keep a patient on continuously infused opioids in particular, as opposed to having to run to the Pyxis, or whatever we're calling it these days, to get your PRN dosing. So that was another common challenge people came up with. So what did we do to help implement the A? Well, we found one of the most important things, and this again applies to every part of the bundle, is to incorporate your assessments into your electronic health record. Sometimes just having the presence of somewhere to document what you're doing actually helps implementation. It's a red flag. Oh, there's another box I didn't check. Maybe I should have done my pain assessments more frequently. So really working that into the medical records. Having a strong MD champion, in particular with pain, so the nurses in particular are empowered to have the ability to treat their patients' pain effectively. Doing a lot of education when it comes to what tools you're using, and that emphasis on treating pain first. Let's get our pain under control before we move to sedatives, and move to sedatives if needed. Now, the education, what our teams are telling us, it's okay if you want to go the traditional education route with teaching people how to use the tool. What the people that have had the most success have told us, it's more important to focus on the why. Why do we need to focus on pain first approach? What have previous patients told us? What have our previous experience have been? But more importantly, what are the long-term consequences of pain? So really getting that emotive response from team members in terms of that sharing patient stories and successes in that way. Having pocket cards, not a really new implementation strategy, but the importance of having in your pocket all of the things that tell you how to use these new tools that they're trying to implement into everyday care. And also a lot of teams reported having success using things like PCA pumps, which gets around one of those barriers, having to run constantly to get more pain medicine. Strong acute pain management team. We're finding that those sites that have in place palliative care services or already have in place an acute pain team, relying on them for their insight and some guidance on how to do these things. One site in particular, and if you're here, kudos to you, really mentioned the role of physical therapists in pain management. How cool is that? So the physical therapists in this site actually started implementing non-pharmacologic interventions during their physical therapy session. How great is that? Hot, cold, the stuff that we're really taught in Nursing 101, those non-pharm pain management strategies that sometimes are difficult to implement because of pain, but pulling in other members of the interprofessional team to help assess, prevent, and manage pain. And our ICU pharmacists, you'll see again and again throughout the collaborative, the importance of having them help develop the protocolized order sets for these different interventions. The B now stands for both, spontaneous awakening and breathing trials. Now, one of the biggest challenges and one of the most frequent questions that we always get is, when do you do these things? Well, what we found and what the sites are telling us, you do them when it best works for your institution and your unit. Some people like to do it very late in the night shift before the day shift comes on. Other people like to do them once a day, twice a day. What works best for your unit? The key seems to be, what we're hearing from the teams, the key seems to be coordinating the spontaneous awakening trial and the spontaneous breathing trial as close as possible to the interprofessional rounds. And that's important because once the patient successfully completes the SAT and the SBT, you want to have the ability to pull out their tube. So our most successful teams are telling us what worked for us is once we brought those processes as close to possible to when the physician or advanced practice provider is rounding and can give us the ability to extubate our patient. Again, another challenge related to documentation is where are we going to document these things? With the ABCDEF bundle, we have safety screens that guide us through many of these procedures to determine first if it's safe. We don't want to do unsafe procedures. And then we have success failure criteria. Sites are telling us they actually had to do a lot of additional work with their electronic health records to build those safety screen criteria into the electronic health records. So people knew if they didn't get an SAT, if they didn't have their sedative shut off, why didn't it happen? And having that at their fingertips and having the ability, so Ken, my respiratory therapist, wants to know, why didn't the patient why can't I do my SBT? They didn't why isn't their sedation shut off and the nurse is in a room coding another patient? He can click and see the nurse's documentation to see why that didn't happen. Other really unique things that people have tried and seems to work is getting people who are involved in the process, getting their input into the building of those safety screen criteria. listening to them in meetings, or if you want to do electronic surveys or kind of those note boards that Brenda showed before, getting their input. Having people feel as though that their voice is being heard and that they've had some say into what these safety screen criteria should be seems to be very helpful to many people that are doing that. And giving them the opportunity to vote, for example, on the pain tool that they want to use or the sedation assessment scale that they want to do seems to have helped a lot of sites facilitate adoption. Education and consistent feedback. So giving the providers almost real-time information about how good your team is doing in terms of these processes. And are those processes working? How many patients in your unit had an SAT that month? How many patients have got an SBT? So that they have some sense of what their target is, what they're doing well in, and what could use a little bit more improvement. Other sites, one site in particular, was actually able, because of their outcome data, the sites, we did have quite a bit of data collection. But the good news was, because we collected so much data, some sites were able to bring their outcome data back to their administrators, and guess what? Some sites actually got another respiratory therapist or a physical therapist to work on their unit based on the data. So really the importance of collecting that outcome data and sharing it with your administrators. C, choice of sedation. Again, we're not going to use the C word like Marianne says, culture, but really focusing on the pain first approach and really, again, having the providers understand why we want to do that and make that process change. Reinforcement. A number of sites have told us that they've tried and they've had some success, and they have maybe 90% of their MDs, for example, on board with, say, doing a spontaneous breathing trial or not using a benzodiazepine. But then the 10% of other providers come in and say, no, I'm not going to follow that protocol, and then change everything. Well, that's a problem, because then the bedside staff who are caring for the patients really don't have that consistency and aren't sure what to do. So really having that administrative support that everyone on the team is going to get on board and have the same goals and kind of missions. And again, those knowledge deficits that we have. People, for example, have told us that one of the things that helped them with their implementation was when they taught their nurses that benzodiazepines or other medications that we're using actually interrupt the sleep architecture. There's still a very commonly held belief that sedatives promote sleep in the intensive care unit. And we, in fact, know that that's absolutely not true, and it's probably the opposite, that these medications are interrupting their sleep architecture. So very important to let them know some of that evidence behind theirs around. Challenges, I guess everybody could say, we've heard from many sites that their unit has the sickest patients in the country, that their unit has all the alcoholics and opioid abusers, and they have the highest rates of TB, traumatic brain injuries, things like that. So those challenging patients, changing the perception of looking at the 99% as opposed to the 1%. So always acknowledging there'll be those patients that maybe the ABCDEF bundle is not applicable for and you should not do it on, but emphasizing with the staff the importance of giving it to the other 99% of the patients that you'll encounter. Our night shift friends. Night shift, again, does seem to have its own culture at times, and some of our sites have actually done something really neat that I think, where they have their charge nurses starting to round on night shift, and they'll go to those patients at night shift, say 2 o'clock in the morning, and perform a sedation agitation assessment to see what level of arousal the patient's on at night shift. If, for example, the patient's extraordinarily heavy sedated or in a coma, if they're -4 or -5 on the RASS, or even a -3, the charge nurse then intervenes and comes back and says to the staff nurse, do you think we can start lightening the sedation now so that the SAT will be more successful in the morning? So having those night shift rounds. Again, nobody's intending to harm their patients. They're doing what they always have thought was best, and that is promoting sleep, because sleep's a hot topic. Use of actual and target sedation scores. So if you haven't implemented this practice, people are finding this important. On rounds, once a day, the team comes up with what their goal sedation target should be. So if you have a patient on 100%, 15 a PEEP, you might not want them with a RASS score of +2. But having everybody on the team, the respiratory therapist, the nurse, the PTOT, everybody on the team talking once a day, coming to agreement on what that sedation target should be, very important, what they're finding. Good alcohol withdrawal protocols. We have a bunch of protocols that have come out of this collaborative that I'm sure many sites would be more than happy to share with you. So making that interconnection, don't reinvent the wheel. There's not another reason on this earth to create another delirium protocol. Been there, done that. There's a ton of great ones available. Could save you a lot of time in terms of implementation. The pharmacists in particular with the C, what a lot of sites have been reporting us to do, they take ownership of the C. So they are the ones that are looking to see if benzodiazepines are ordered on a patient. If they're ordered on a patient, having those critical conversations with the other members of the team about the possibility of de-seeing them, maybe look at different analgesic strategies if the patients have been getting a lot of opioids. So really, the pharmacist taking a really active role in the management of medications. D. I was shocked, personally, because I kind of live and breathe and drink the Kool-Aid of delirium. But for many sites, delirium assessments were not occurring at the beginning of the collaborative. So a lot of sites had to do that important work of teaching the staff members how to perform accurate delirium assessments. What we found are those teams that take the additional step of not just teaching the nurses, but teaching every member of the interprofessional team how to do a delirium assessment and what the language is that's associated with those delirium assessment, very important. So when the nurse goes on rounds and said, the patient's CAM ICU positive, and the doc goes, great, keep up the good work, that, if you know what delirium, maybe not laughing because you don't know, positive is a bad thing. That means the patient's delirious. But that is key. That is what happened to me sometimes. Having that standard language, very important. Again, those storios and videos, we have some great delirium assessment videos that people have found. What they do is not only do they orient or teach the nurses in their annual training, a lot of people have been putting the ABCDEF bundle training into their orientation packets. So even their brand new nurses or brand new residents, if they're going to be on your unit for a while, have the opportunity to do that. And we're going to get to the F, but engaging family and friends, extraordinarily important for the D part of this, and preventing and managing delirium, having that family engaged with the patient while they're having that particular crisis. Some of the other non-pharm things people are using at our sites, TV and music. So just looking at the TV to make sure that it's not on, who's that guy that used to smoke and throw chairs all the time? He's probably dead by now. Jerry Springer, Downey Jr., something like that. But, that your 85-year-old patient's not lying in bed and listening to hip-hop music. Really engaging them into what their likes and dislikes are in terms of relaxation. Using the ICU diaries that you've probably heard about in a number of these presentations. I like this, even though it's Go Blue Michigan. I had to call out University of Michigan because one of the questions that we face is that once we lighten these patients, are things like restraint use and stuff going on. Their work, in particular, they've been phenomenal in that they've been able to accomplish a lot of these interventions without increasing the use of physical restraints. So it is possible. It gives us hope that we can do these together. Now, E has been voted the sexiest intervention in the ABCDEF bundle on numerous occasions, like Brad Pitt level sexy. E is all about it. There you go. Well, we have our own E. Heidi probably is the Brad Pitt of the E. But the E is really the one that everybody tends to kind of gravitate to, really want to get this, really want to start mobilizing their patients. Importantly, as been pointed out before, we cannot mobilize our patients if they're deeply sedated. So again, all of these processes, like Brenda and Marianne said, are so interconnected that if you're going to you can't start at the E. We would love to, and Heidi's argued, but if you focus on the E, that's a good thing. If we want to get our patients up and mobilized, what do we have to do? That promotes you to start thinking awake, alert, oriented patient. Bariatric patients had a great, again, that's one of those things everybody thinks they have the most of. We have the biggest patients in the country. But bariatric patients and the amount of nursing workload in particular that comes into caring for patients that are a little bit heavier is a really challenge for early mobility efforts. And really has some unique ways to solve that. Facilitators, everybody's equally important stakeholders in this E. Really engaging the whole team in that planning, relying on our physical therapy experts to teach us the best and safest way, in particular with those 1% challenging patients, on how to mobilize them. Focusing on little goals. So you're not going to go back and mobilize your patient that's on 100% 15 a peep unless you live in Utah. Isn't Utah like the really good site? So really focusing on little baby steps. And again, having the resources that you need. Sites have been investing in lifts in the ceiling to help with the heavier patients, having their patient care technicians taking ownership of that early mobilization on night shifts so that they're up on day shifts and able to get their SATs and SBTs. And then, I love all these team pictures. Finally, with the F, really another part of the tapestry that the sites that we've been working with in particular have taught us so much about. They've had some really creative things in terms of engaging their families. So, for example, they've done things like we have a number of already developed ABCDEF-related posters that can be displayed in patient care area, where the patient's family stays. Engaging the family members on rounds. Also engaging other team members like social workers, chaplains, people that that are really well suited to engage family members. Milestones chart. One of our sites just passed this, I think it was like last week that we learned about these milestones chart. But really having a picture so the family sees all the small steps that the patient's making throughout their stay in the intensive care unit. So lots of engagement. Lots of other suggestions if people are interested. We have a lot of engaged sites that are more than willing to share the work that they've done with you. But I'm going to leave it now for our fearless leader to tie everything up, and then hopefully we'll get a ton of questions from you to help us learn more. But again, thank you everyone who's taken on this important effort and for everything that you've taught us.
Hi, I'm going to follow Michele here, but we're going to show a video first. So I was stumbling because I thought somebody else was going to play the video.
At the Polymomy Medical Center, they come from every corner of the hospital, from every discipline at one time in one place.
For extended IV care.
So when we found out that the Society of Critical Care Medicine was asking for different facilities, to be a part of this, of course we thought, well, how could our ICU possibly be a part of this big collaborative, right? We're just, a small facility in the island. But we thought, let's try and submit an application anyways. So we submitted an application, and I believe hundreds of other hospitals did as well. And fortunately, we got the news that we were chosen to be a part of this collaborative.
At the intensive care unit, the multidisciplinary team is gathering for its weekly rounds, where doctors, physical therapists, social workers, and more exchange updates and share information on every patient in the ICU.
It starts from the night shift.
By 8 a.m., ICU nurse Ditas Agustin and charge nurse Jay Ofalsa are wrapping up their shifts and carrying vital information for the team.
If there's a moment in time where things can get missed and lost, it's probably between change of shift, and that's where we try to focus a lot of attention.
They would do their own assessment too, but of course they can all base what they're going to do for the day shift on what we experience.
We go through the patient head to toe. We open the computer, look at all the information, all the labs, all the imaging reports, everything. It's just so we get a full picture and we don't leave any stone unturned.
We really went from being a lot of individual specialties to really being a unit. It's the intensive care unit, and I think we really changed our identity as being just individual practitioners working in a place like the ICU into really an intensive care unit where we're all working together. We know each other's names, we see each other daily, and we can really come together as a team.
And it's not just for staff anymore. IC Medical Director Dr. Emilio Ganitano says visiting families are encouraged to join in, share their thoughts, and be a part of the healing process.
The ICU is a scary place, but I think one of the things that can alleviate that fear is really being able to involve the patients and their families from the get-go.
In November 2015, Polly Momi was selected to be a part of a quality improvement project called ICU Liberation. The 18-month initiative aims to reduce the debilitating impact of intensive care and keep the focus on the patient. Polly Momi was the only facility selected from Hawaii, joining 67 other national hospitals. Part of the national collaborative is building what's called an A to F bundle, and it starts with assessing and treating pain.
A lot of times in the ICU, we have a lot of medications that we're giving these patients, and we want to make sure we choose the right one for them. Well, new studies show now that we shouldn't be keeping them sedated for too long because there's too many side effects that can occur from this.
It has led to many dramatic changes in the ICU. For one, Jackie Skotka, Director of Respiratory Care and Rehab, says the number of days a patient is on a ventilator has dropped from 5 to 3, a potentially life-saving difference.
When a patient's on a ventilator, we're breathing for them, and that's not natural, right? And it's opening them up to opportunity for catching pneumonia and making them even sicker than they already are. So the goal is to be able to get them off that ventilator and back onto breathing on their own as soon as possible.
And only 7 months into the program, Polly Momi's ICU was already working with Hawaii Pacific Health's EPIC team to create improved flow sheets and better chart patient assessments. Quality data technician Colleen Rosenow says it's not only more efficient, it's giving staff credit where credit is due.
This is improving the care that we're giving our patients, their quality of life here, the things that they do with their family. So, I mean, it's really nice to see that our hard work is being noticed.
The ICU Liberation recently awarded Polly Momi with 6 certificates of achievement, reflecting the center's advancement in medical records and family participation. Practices not only surpassing industry averages, but now being adopted nationwide.
I think the most exciting part about this is that we're just getting started, where we're all working together. We know each other's names, we see each other daily, and we can really come together as a team.
Back in the ICU, it is a stunning sight. Staff helping one patient do what was once considered unthinkable. Still strapped to a ventilator, now up and walking.
And we're doing more with them. We're getting them up and moving.
Rehab manager Cheryl Nakanishi says it has been a dramatic change from a rest and recovery approach to making the muscles, heart, and lungs move and move early.
It's actually a big deal. It's a big deal to the therapists, it's a big deal to the nurses, but it's the biggest deal to the patient and the families. It gives them something to look forward to, some kind of hope that they're on the road to recovery.
Fewer and more select medications mean patients are more alert. Hands-on exercises mean patients are more mobile. And that open door, open mind policy means family and friends are so much more part of the process.
At the end of the day, we're all about putting the patient at the center of care.
And giving families the kind of quality comfort when they need it the most.
The biggest thing is the teamwork, though. You can see how the team came together, so they all helped to make it work.
Wow. Where's the Polly Momi team? All right, which 5 of you are walking up here right now? I'm serious. Come on up. 5 of you come up here. 5 of you come up here. Come on. Don't make us wait. 5 of you, not 1, not 2, not 3, 5. I know they have more, but I'm getting 5. There's only 5 chairs. Thank you. That was great. See, it's fun to meet the stars of the movie, right? You want to meet the stars of the movie. No, seriously, that was a beautiful depiction. I heard things like hope, meaning, identity, gave them something to look forward to, beautiful teamwork, This is fantastic. And our tech folks here, if you can make sure these microphones work, that'll be very helpful. So what we're going to do, what time is it? 12:40, and we have until 1:30, right? We can finish a little early. Early is good. But we're going to have a panel discussion after this as well, because a lot of these people up here have answers they want to give. So I figured the way I would use my time is to let you teach us, and I'm going to ask you some questions that I'd like for you to teach us what went down, okay? And then others can ask you questions as well, and then we'll have the panel discussion. So maybe we'll do this for about 10 minutes, and then we'll have the panel discussion. The first thing that I wanted to ask you about, and just this is off the top of your, off the cuff here, you can answer however you wish, whatever, but Heidi Engel was telling me that one of the things that happened at the Zen Hospice Project for dying patients that I showed earlier this morning in our physician-assisted suicide euthanasia talk, where I was on the con side of that, was that at the Zen Hospice Project, they give people their identity back. That when you walk in the room, you can see them. They have even maybe artwork, pictures of their life, whatever. And I said, you can do that in the ICU. And we've done that in our ICU where people had enough pictures up that when somebody walked in the room, they could see who those people are intubated on the blower in the ICU. Has this moved you in that direction about giving people their identity back? And maybe it's not pictures in the room, but how has the A to F bundle helped you to personalize people that might, in the old way you were practicing ICU medicine, may have been more kind of a bump on the log, a patient in a bed on a ventilator. Just anything, just teach us what you have learned through this process.
Well, I think one of the probably most telling parts is the fact that, prior to this, we probably had our patients, sedated and immobile. They're knocked out. And in a lot of ways, you objectify people, and like you said, they're literally a bump on the log. Versus now, they're usually awake, interactive. So you can actually talk to your patients, which, as intensive as it's kind of this weird thing, like I'll talk to a guy that's intubated. But, being able to talk to the patients, I think it's changed a lot of that. And I think the one thing we noticed even early on was that the families kept coming up to us and said, hey, prior to this, whenever we had our family member in the ICU, we never had this experience where they're awake and alert. And now it feels more like they're people, and that we look forward to them getting out of bed and moving around. And in a lot of ways, it's really treating them like a person rather than just an object in the room. And families have noticed it really early on.
Great. Some others share with us, please, if you have any other comments.
Like Dr. Ganitano said, it makes the families feel more hopeful. Instead of the patients lying there, the families come in every day thinking, are they going to get better? Can we see progress? And when they see their family members get up to the edge of the bed or walking, it gives them hope for more. And that's the biggest thing.
It's a big deal. One of the things that I learned a lot about in this talk this morning was that people are clamoring in many places in the world. This is going to seem like a shift, but I'll bring it back. For example, physician-assisted suicide and euthanasia. And the thing that I said this morning in my 8:30 talk was that if people have a why to live for, they can get by with almost any how. It's a Nietzsche quote. And Viktor Frankl used it in his book, Man's Search for Meaning. If people have a why to live for, they can get by with almost any how. And what you just said is that you're giving people a why to live for. You're showing them that even through the suffering, there's meaning there, there's joy to be had, there's family members, there's fruition and healing of relationships and moving back to their life. They're seeing a light at the end of the tunnel, perhaps more than they were before. Mm-hmm. Yeah. Do either of you have any comments or thoughts? What are your roles, by the way? Tell us each your interdisciplinary role. Go ahead.
I'm the ICU medical director, the intensivist.
Okay.
I'm the ICU manager.
I'm the director for respiratory care and rehab services.
And I'm the manager for rehab services.
Okay, well, great. So respiratory care and rehab services. Tell us your thoughts, because you play a different role on the team.
Yes, it's a big difference. When we worked with patients before, they would be in bed, sedated, and we'd do range of motion. And we wouldn't be able really to get to know the patients or interact with them. And so now when we're working with the patients, they're awake and they're up and they can interact with us. We can get a little bit more information about what their goals are, what they want to do. And so it makes a big difference for how we are working with our patients.
Okay. Mike?
Sorry. That particularly about involving the family? Is that what you're asking? Okay. The respiratory therapists have gotten a lot closer with the family members, trying to find out what the patient maybe would have done beforehand. They've talked about what we can get them back to doing, and the fact that we're getting them up when they're on the ventilator and moving has been very exciting for them. We have a few patients that live on ventilators, and they come in occasionally, and they have gotten very close with those family members.
Great. Okay, good. So that's a good start. I want to say a couple of other things. One is that when you were talking about them being awake more and them being more engaging, I will tell a story that I was asked by Thomas Strom, who published in The Lancet the no sedation paper. Some of you know this randomized controlled trial that was in The Lancet. And so I was the evaluator of his PhD thesis, which was using no sedation. This was in Scandinavia. And I got on the airplane and flew all the way to Scandinavia, having read his paper in the Lancet, thinking that, maybe it's real, maybe it's not. I kind of didn't know what I'd see. And they walked me around in the ICU, and this was maybe 6-7 years ago, before people really got on board with this enough, and everybody was awake. Every single ICU patient was awake, and they were all intubated and awake. And I thought, wow, this is really qualitatively different than anything I've seen in an ICU before. And so they made a believer out of me, and it was beautiful. Now they're doing their second no sedation study called No Seta, something. I don't think Tom's in the room here, but he's at the meeting. Oh, there he is. Tom, come up here then, please. Come up here. There he is. Come on, Thomas. Thomas, come up to the microphone if you want. That's a good. I want you to tell them what your new study is, what you're moving the data forward with from your original study, and now that I've set you up as this avant-garde change maker in the ICU, they can hear from the horse's mouth himself.
Thank you very much. Our recent trial is called non-SIDA, and it's the same endpoint as the first trial, but now we do it in units who normally do sedation. So in order to show that everyone can do it, if I just might add,
please add
my
whatever.
thinking was that when I visited US just before we published our first trial, I gave a brief talk in the US, and everyone in the room said, where did they dig that guy out? Awake patient, no way, we're not going to do it. Now we have a room saying most of our patient is awake. Wow, amazing. I want to clap on you too. Yes.
Now stay there. I want to keep building on this theme, non-belief. When we first finished, I meant to say this during the plenary earlier, but there was just not enough time to say everything. But this is a true story too. I don't think Pratik's in the room. But when we first finished our ABC study and published it in Lancet in, I think, 2007, 2008, I deliberately wanted Pratik to get out there and do the talking. So Pratik Pandrapandi is one of my partners at Vanderbilt. He's an anesthesiologist. I'm the pulmonary critical care side. So we got both of those in leading this ICU Delirium group on it, two of the physicians. So I sent him to Berlin to present the data. And Pratik gets in there in Berlin. I'm in Nashville by design, and he gets killed. I mean, torn apart by the likes of the names of the people you know who are the biggest names in critical care, which I won't mention any of them. But they ripped him a new one, no kidding. And it was super embarrassing for him. They basically got there and said, "This is this isn't real. I don't know who you enrolled." They didn't believe it. Oh, and the others who didn't chime in as much came up to him afterwards and said, "You know what? We're already doing this. We're already fine on this." They were from different countries in Europe, and within the next 6 to 12 months, those people went back and surveyed their country to prove that they already did what we were talking about, and their numbers were in the garbage can. I mean, what they thought they were doing and what they were actually doing was two totally different things. They thought that they were having no sedation, no SETA, and they were basically using gobs and gobs of benzodiazepines and narcotics, and they weren't, it was night and day situation. So comment on that, Thomas, about this miscommunication or this misperception, rather, about what people think they're doing and what they're actually doing. And by the way, you may have missed what he said, but he's now studying it in the other ICUs. So their ICU was kind of like a believer, and now they're studying it in the non-believers, which I think is a beautiful expansion of your data. And then I want to come back to our panel because I have another question for them.
Okay, you want me to comment on
disparate between what you think you're doing and what you're actually doing, what you found even in your Scandinavian ICUs?
Yeah, well, many of the participating centers actually said that they think they were doing no sedation, but when participating in this trial, half of the patients actually needed to be not sedated, and they could do it, and it was an eye-opener for them. So by entering this trial, many units adapted this strategy. So it can be done, as you guys showed. So, yeah.
Okay, thank you, Thomas. That's great. Glad for you to be here. Okay, back to our panel then. So my next question is, and when we do the panel discussion in a few minutes, when the other people come up here from ICU Liberation, we're going to talk more about the why and the how. They're giving us the why. We'll talk about the how and the nuts and bolts. But I want you to tell us more about, at your own hospital, when you had to go and get buy-in from the bean counters and the CEO or the people who run the hospital, not the clinicians at the bedside. Was that hard? How did you do it? How did you make this real in your ICU? Because, bear in mind, your video said that you took ICU length of stay, or was it ventilator stay, from 5 to 3 days. That's a huge deal. But they didn't know that was going to happen when you started. You may have talked about other people doing it, but they didn't know if it would translate into reality for you. So how did you win them over?
I think we were very fortunate. I think when we started at the top. We went to the CEO, and said, hey, for one, we want to join a national collaborative, which we have never done as an institution. And we, kind of sold it on its merits. And I think, again, we were lucky, because I know everyone else doesn't have this, but, we were very lucky that the senior administration was on board with it. So that, of course, helps us down the road. And then we were able to get good support from, I think, to be honest, getting support from our IT department and our electronic healthcare records was a huge deal, because then we could use data to drive, it'll feed back to the senior leadership and drive it. And then I think what we did was kind of what you all taught us. We told a lot of stories. And as we went through, we shared our success. Getting buy-in from the multidisciplinary staff was, as expected, a challenge, but really, I think focusing on why we're doing it and explaining to them and trying to get them to understand why we're doing it and why we're changing the way they've always done things, I think was a huge thing that we did early on that I think helped us. So I think when we came back from the first meeting from the collaborative, we had one big meeting. It wasn't just the nurses, it wasn't just the docs, because we basically broke down the silos and had one big meeting with all of our ICU staff and said, hey, this is what we're doing and why. And I think having us all work together and breaking the silos down early on in the process has really helped us to be successful down the road.
He answered everything.
Others in the room might want to talk to you when the session's over. We're going to finish a little early, so you'll have time to grab these people. We want people to learn from you, real-life examples in a non-study setting, in a community hospital. That's a big deal. So congratulations to that. My last point, and then we'll move to the next panel discussion. Earlier, we were talking about Marianne Barnes-Daly's paper and the fact that she showed a dose response of every 10% increase in compliance, 15% improvement in survival and time without brain dysfunction, coma and delirium. I didn't talk about all or nothing compliance, and I didn't talk about the IHI definition, which is all or nothing. And the reason that the IHI originated this definition, there's a take-home lesson in this for us. So the IHI's definition of bundle compliance is you either do all of the bundle or you don't get any credit. Okay? Now, that's pretty harsh, but there's a reason, and I want people to know this. So when you go back to your hospitals, you can push for total compliance. That's why I'm going into this math a little bit. If you say that somebody with A is 80% compliant, B is 80% compliant, C is 80% down the line, and you multiply that out, 8.8 times 0.8 times 0.8 times 0.8, that number gets pretty darn low. And so IHI, the Institute for Healthcare Improvement, is basically saying, look, we want better than that. We want more than that. And so I ended the previous talk by saying, look, we're not there yet. We're moving in the right direction, but we're not there yet. And for you to be able to shake down your length of stay by 2 days is a big deal. But I think even you would probably say, or actually let me close on this question, and I'd like to start actually down at the end with the last two people. Do you think you're there yet with SATs, SBTs, rehab, et cetera? Because y'all are in charge of the ventilator and the rehab stuff. Where are you with that? And you've done a great job, so we're all here to thank you for that. But let's air our dirty laundry here. And do you think that you're good enough yet?
As far as the B element, we look at it. I look at it daily, but we fast look. Don't have a whole lot of time, but we are consistently in the high 90s percentile.
Wow,
96 to 97%.
Okay, very impressive. How about rehab? Rehab mobility.
For rehab mobility, we've come a long way, and we're doing a lot better. We're getting a lot more patients up, but we're constantly pushing to do more. We want patients to be getting up every day. We want patients to be doing more. So the first step that we were working on was to have patients sitting edge of bed. And our next goal now is to make sure that the patients are taking the next step and that they're standing before they leave the ICU. And so we're doing better. We still have a lot to go.
Okay. And keep that in mind when you look at the overall compliance and multiply each individual at how low that number gets. So that's just kind of something to push you to the next level, okay? Thank you tons. Let's hear it for the Polymoni group. And I guess we can shift over to the panel discussion. Thank you so much. Okay, thanks. Who's coming up? So we don't have to fill this time, but this is a time for you to ask the nitty and gritty burning questions that really bug you about things. What have we said? What have people talked about that just don't sit right with you, that you haven't found to be true? What have we not addressed that we should have addressed? What have you found to be too difficult, and you want to know how to fix it? And so let's allow people to come up to the microphone and ask these questions, and then I'm sure the three of you can think of things that you would like to chime in as well. Please, sir.
Jeff Dichter from the Twin Cities. So ABCDEF, that's 6 pieces. There's a lot in each piece. Do you do it one piece at a time in a unit, or do you try and do them all at once, or how do you kind of approach that one?
I'll start by saying there seems to be kind of an innate progression through implementation of the bundle elements that I've seen in my own hospitals, and I've also seen across the country, where, as we mentioned earlier, you can't walk a person who has a RASS of -4. So typically, folks start with overall lightening levels of sedation and having RASS targets that inform the implementation of the rest of the bundle. And to do that, nurses have to understand how to do the RASS and how to meet target sedation scores, and physicians and providers have to order correct levels of sedation. Once the patient's awake, you can then assess them for the presence of delirium, and so on. If a patient isn't awake enough to breathe on their own, the spontaneous breathing trial is not going to be successful. So I have seen teams start with reducing overall level of sedation, moving toward SATs, and the other bundle elements sort of fall in place. That said, there's no cookbook method, and depending on where you're starting and that you want to end with all or none compliance, you should get some information about where you are right now and see what the next step is for your unit with the ultimate goal of all or none compliance.
The one thing that I would add to that is I've seen folks start in a staggered way like that, but forget the big picture. So I think it's really important, and one of the phrases that we use in this collaborative is the business idea of zoom in, zoom out. So you've got to keep it before your team that this is a bundle. These things go together, and they're more powerful together. And so this is where we're going. Here's the big picture, but let's zoom in and work on this. And let's zoom back out and keep that idea that we're in this big bundle together, because that helps make the connections that this one element that we might be focusing on for a couple months is interconnected to these other elements. So maybe if I'm changing sedation, it helps to communicate that I'm actually doing that because it's a delirium approach. I'm reducing delirium or potentially reducing it because I have the sedation strategy. And so I think helping explicitly make those connections before your team is really important in however you roll it out. But keeping the big picture in mind the whole time, I think, is really key.
And when you run this down in the rounds, I'm glad you asked it, it doesn't take that long. You know, the individual things at the bedside, the therapist doing the SBT after the nurse has turned off sedation, and then the person coming in and getting now the physical therapist doing mobility, this might take an hour and a half, 2 hours to look throughout all these things. The monitoring itself doesn't take nearly that long. Doing a CPOT, a CAM, and a RAS, for example, this takes a matter of seconds. And so on rounds, when the nurse presents the data to the rest of the team, they run through the A to E in a matter of 15 seconds, 30 seconds max. So on rounds, the actual physical communication of the information, which is so vital, which you have to do, say out loud, 30 seconds. Not really laborious. Next question, please, sir. Tell us where you're from and what you do, and then the question.
Hello, my name is Anthony Bush. I'm with Emory, the NPPA Critical Care. I just graduated in May, and this is my first conference. And, you know, coming in and starting to learn how to, you know, deliver care. And, you know, I think one of the biggest questions I have is how do we manage good sedation? And, you know, it's so easy when somebody gets irritated with that tube and starts bucking the vent to just knock them down. And how do you really get people to handle that? And I guess it's a two-part question. The other thing is like with the Society of Critical Care on how, like, could we maybe make like YouTube videos on how to like mobilize these patients on getting them up and out, so that way we have a resource that we could just go to. And, you know, because I feel like mobilizing that patient is like, it scares me because I don't want to extubate a patient, you know? So I guess those are just some things that I'm thinking about as I come forward and things like that.
Yeah, I asked Heidi Engel to come up here. Others may have a comment, but thanks. And by the way, my daughter's a pre-med student at Emory, so go Emory. Heidi, here. One of the big things that we do there is mobilize the patient when they're agitated. Instead of the old way slamming them back down with drugs, it's actually needing to get them out. So Heidi, can you comment about this a bit?
Sure.
With agitated people when their sedation stops.
Yeah, so one of the best things you can do, and I think the Strom article talks about this quite a bit, is talk to the patient. So my great strategy, I'm a physical therapist who works in the intensive care unit at UCSF Medical Center. I've been doing this for 10 years in the ICU exclusively and 20 years before that. And I have this great trick for mobilizing ventilated patients. Our ventilated patients get up and walk around the ICU. And my great trick is I walk into the room and I say to the patient very specifically, "Hi, you're in the intensive care unit at UCSF Medical Center. You've been very, very sick, and so they had to place a tube in your throat to allow you to breathe. Breathing is really important, right? Can you nod your head? Do you understand? Okay, good. That tube is uncomfortable, and I'm really sorry about that, but please, please, please don't touch that tube. Try to calm down. Your sister is here, and she will tell you everything is going to be okay, and you're in the right place, and we don't mean you any harm." So, and then we pull the sister in there, and the sister talks into the patient's ear and just repeats everything I just said and tells that patient, "Please be calm." And then I say, "And I'd like to get you up. Would you like to get up?"
Tell them why you said that. We don't mean you any harm.
Because that's what people imagine, that they think they don't know. They believe they are a prisoner of war. So your patients believe that aliens captured them, or they believe that somehow they became a prisoner of war. All they know is they woke up and there are things shoved down their throat. They're not able to talk or communicate. Somebody tied their arms to some bed rails, and they're getting wild, trying to escape. That is a very natural tendency. So all they need is someone to explain reality to them, to give them a very specific guideline to not touch the tube, not pull it out. It's going to be okay. They won't remember, but you'll just keep repeating it. You have to be very firm about that aspect of it, but then when you get them up moving and everyone's getting a little excited, then you become very zen, right? It's okay. It's calm. This is normal. Upright is normal, right? We don't live our lives in horizontal. We live it upright. take a deep breath. We show the patients the tidal volume on the ventilator all the time. We tell them, make that number higher. I mean, it's not rocket science. It doesn't require much, but it makes a huge amount of difference. If I turn off the sedation and I leave the room and I don't say anything to anyone and I don't have the family member standing at the bedside telling the patient what is reality, then they still think they're in your prisoner of war camp and they're fighting to get free. Is that what you want me to say?
Jeff.
I'm Jeff Wright. I'm a medical director of critical care at Baptist Memphis. We're part of the collaborative. I would love to hear suggestions, feedback. We've managed to do, I think, pretty well on the A through E parts. We're up to consistently 96 to 99% compliance on A through D and about 80% now on E. But we auger into the ground at family engagement empowerment. And I wondered if you could make recommendations for what you think are the key elements of that family engagement. What do you, if of the interventions that you can do at the family level, what are the best ones?
Yeah, this is great. The four women up here are going to comment. Heidi specifically already asked to comment about this. But by the way, Jeff is another shining example, like Polly Momi, of a great hospital in Memphis, Tennessee. He's a former Vanderbilt fellow of ours who's done this super well. I'm amazed, though, at how much difficulty you've had at F. So do you want, before we start answering, to tell us why you've had such a hard time at F? And then these four women are going to shine some light.
Well, I think part of it is it reflects a little bit on our community. We're an impoverished community. So, for example, one of the problems that we have is families can't be there during the day because they have to work. Our poverty level, we're 60% African American, and our poverty level is about 60 to 70%. So that's part of it. I think that's a key part of it. Part of it, with all of our bundles, one issue is always just the compliance part is actually just the documentation part. Just remembering to click the box. We've worked a lot on our medical record system to make that better. But we've still had troubles, I think, with the family engagement. And part of this, we've had a lack of, we haven't been able to pick what best to focus on.
Let's help you with that. Why don't we start with you, and then we'll go Michele, Marianne, and we should spend some time.
So I often say that I think F also stands for free labor. And I say that because, as Michele said, none of us have enough hands. And if you're going to do the mobility part of it, which means out of bed and out of the room, it's going to take extra hands no matter what. But they do not have to have an advanced degree. It doesn't take an advanced degree to push an IV pole down a hall. It doesn't take an advanced degree to keep a chair behind someone. It doesn't take an advanced degree to comb someone's hair once they're sitting up in the chair so that they feel like a real person again. And when you can, whenever the family be there, pull them into the room and let them know, it will really help me out a lot if you could pick something that's meaningful to the patient. Comb their hair. I had a woman, we got up the other day, and she was really distressed because she was a hairdresser, and she realized that no one had combed her hair for 4 or 5 days, and there were knots in it. So can you get the family in there to help comb the hair? When you give them tasks that are meaningful, they find a way to come in. And mobility and occupational therapy type of tasks and some nursing tasks can be very valuable to the patient. And when the family realizes that you, the provider, don't necessarily have time but know that's important, they find a way to come in and get it done, I think.
I actually got in trouble for this one because I thought at the very beginning, empowering, engaging meant letting the family members do something. And then I had a wise old mentor reflect back to me that she would be absolutely insane if an ICU provider asked her to do range of motion on her patient. So my takeaway from that, I think the most important thing that we can do is ask our family members how they want to be involved and what they're comfortable being involved with. and not make assumptions that like what we think might be best is best for them. So like I thought, oh great, we're going to have all of our families do our stupid range of motion that doesn't do anything. And she's like, if anyone ever asked me that, I would be so infuriated with the ICU staff. So asking the family what they need, what their patient would like, and engaging them that way.
Because some family members want to do range of motion all day long. They come in a lot of varying approaches.
Mm-hmm. I think that was a great question. Thank you. And it is something that a lot of folks struggle with. And unfortunately, because it's the last bundle element, it often gets the shorter shrift in my experience. So I would say when you look at family engagement and empowerment, there's kind of 4 levels, right? So the first level is how much information are we providing to the family? And if you have working families who need to come in the evening, then you need to make it a priority. One of the things we do in medicine in general, but in the ICU specifically, is do things at our own schedule that work for our schedule. And sometimes when we realize we need to put the patient at the center of that, then we need to change the way we do things. So providing information is the first one. Allowing patients and families to be present so that they can see what's happening and feel good about the care that we're providing. The next step is allowing them to be part of the team, creating the plan of care, right? And then the last thing is how do we engage them in the care whenever possible? And I think we've heard some things from Michele and Heidi about that. So when you think about what your struggles are, just answering the question, how do I fix my F? First, get a team, a multidisciplinary team together of respiratory care practitioners. Physical therapists spend the second most amount of time with patients than nurses do, right? Making sure you have them. Get a team together and identify what your barriers are first, because we can't answer your question. You gave us one barrier. So a lot of times what people struggle with this bundle is how do I already have rounds, how do I get the A through F bundle in there sufficiently? And you can go through it in less than a minute, but my experience is that when you're talking about it, it takes longer than that. So what if you did general medical rounds in the morning and you did A through F rounds in the evening when family members were there, and you could include them as a part of the care team? Just a suggestion, not a solution or answer, but I think there are out-of-the-box thinking about maybe having rounds twice a day, having bundle rounds again in the afternoon. And sometimes providers can't be there. I have teams where I have charge nurse-led rounds. And sometimes it's just sharing information among the team and also with the family and the patient themselves. So there's out-of-the-box thinking about how to respond best to the barriers that you're encountering based on your own specific circumstances.
Now, before Brenda goes, is Judy in here? Where's Judy Davidson? Judy Davidson has just been the real champion behind the clinical practice guideline for family involvement in the ICU. And she has done an incredible job as a leader in our community here. So we really want to learn from her. If any of you want to go and read her work, you can look up this CPG. Brenda might get into that a little bit, but we really want to give a shout out to her incredible leadership in this regard. Brenda?
Well, I would echo that, and I think that those guidelines were just published in this version, this month's version. I always get the online and live months mixed up. The one thing that, having been a family member of an ICU patient that's in another state and not able to get there, I often think about what did I wish that the ICUs did better with me. And what I see some of our other collaborative sites doing that I think is really creative is creating an orientation packet. And that can be a trifold brochure, so it doesn't have to be a multiple page thing. But that includes the best ways to communicate if you're not there. And I think that was always a struggle, or has been with me and my mother, is how do I get in when I can't physically be there? And other than my brothers putting speakerphone on. And having a physician tell them, I don't talk to phones. And they said, well, we'll just hold it here and we'll repeat everything she's saying. So finding a way to invite them into conversation and invite here's the best way. If a lot of people aren't going to be here, well, what are effective strategies that have worked when they haven't been there? And how do we say, you're welcome to communicate with us this way, come in this way? And I think having that in your welcome to the ICU packet would be really great. And I think also in that of a list of things they can do and are helpful for them to do that says, ask your nurse about the following. And that helps to start that conversation, equipping the nurse to be accountable to the conversation, and allowing inviting the family member to the conversation of, maybe I want to be involved and I want to be there and I'm going to come in the evenings. And maybe if that's the case, that you find out more families do come in the later evenings, that you divide that list up. If you can be here during the daytime, here's some things that really work great and you could help us with. If you're coming in the evenings, here's some things that really work well in the schedule or flow of what we're doing. I think those types of things really help to communicate. We'd like to have you here if you can make it, but if you can't, we still want to communicate with you. But I also want to point out, I think you nailed one big point, is there are communications that happen that are never documented. And I think for all of us, because it is so interprofessional, the ways that we interact with these family members, finding some centralized place where we can communicate to one another the communications we've had with family members is a challenge. And I think Palimomi really hit the nail on the head as well, that one of their main stakeholders that had to be involved in the project was IT. And helping to get an advocate there that can help you say, okay, this is in 7 different places. None of us look at those other 6 places. How can we get it into one place and an easier place for all of us that we will actually click that button, and so we can keep that communication and handoff going from colleague to colleague.
Beautiful. Let's go to our last 2 questions, and then we can call it quits.
Hi, I'm LV from Washington Hospital.
Others can ask questions too if you want.
LV from Washington Hospital in Fremont, California, and we are part of the collaborative. I just wanted to share one thing and then ask another question. So what I want to share is when we do our A to F bundle rounds, we included the alphabet, a little bit more of the alphabet. We included G for glucose, H for hospital-acquired infection, and I for INO infection. So we really cover a lot, and the staff are so used to going A, B, C, D, E, F, G, what's a glucose?
Yeah. And let me empower you. I know you have a question, but let me empower you about that. But I just literally just got a text from a woman named Karen Korzik who has a G. This is at Geisinger in Pennsylvania. They have G goals of care. So we won't formally change the name of the bundle. It'll stay A to F. But people are going down to Z on this thing. It's fine. And I just want to empower you to say this is what we talk about when we say this is not cookbook medicine. It's not a one-shoe-fits-all sort of thing. Personalizing this at your center, that's great. We love it.
Yeah, and it makes it more fun,
Yeah, absolutely. Personalize it. Go for it.
We go G, glucose, and then what can we get out? Get it out. Yeah. And then to prevent hospital-acquired infection.
And this G for goals of care was about palliative care, FYI. Okay, what's your question?
So my question is, since all the staff are so used to the A to F bundle, when we come to a patient that's not intubated, they want to do an SAT. So I was wondering if other, they're like, how do we do an SAT?
People get excessive sedation when they're not on a ventilator sometimes. That happens. So the SAT doesn't have to only be applied to people on mechanical ventilation. Maybe let's ask Michele Balas or Jed if they found this in their 2 studies. What was the situation with doing SATs and SBT, not SBTs, but SATs in the non-vented patients? I know that Jet had data on it.
Thanks, Wes. Let me tell you what happens in my hospital. So we get really great at having low levels of sedation, and even if patients are on low levels, doing SATs. And then we do a great job of mobilizing them, and they go out to the floor. And you know what they get? Sleeping pills and all kinds of benzodiazepine intermittent dosing, and they're zonked, right? So if I had to institute an SAT on a patient who was not on continuous sedation, I'd go out to my med-surg units and do it at night, because that's when it tends to happen. We didn't require an SAT on someone who was not on continuous sedation, so I actually don't have a comment on that. But I will say that patients can get oversedated on oral agents, and that's definitely something to have. What you can have for patients who are on a continuous sedation is still a target RAS. We have a target RAS on every single one of our patients, whether they're on sedation or not. And so if you realize that an oral agent that's either ordered and or administered is taking a patient deeper than their target RAS, which for us is now -1 to 0, then that needs to be addressed in rounds as part of the SAT discussion.
Speaking, by the way, Michele, let me ask you, did you notice in your study if people went backwards after they left the unit? Like, is there a situation now where we're getting better in the unit, and then it sucks on the floor.
Yeah.
So can you talk about that a little bit?
So I think that's a great question. We actually wrote a paper on it if anybody's interested on extending it to the post-ICU setting. We know that immobility is very common, particularly in the older adult population. So what we're hopefully going to start focusing on maybe next collaborative, we're thinking about stuff to do again. But this does kind of, the whole approach to light sedation, mobility, preventing infections does need to be extended post-ICU stay. So once you got it up and great, like our Hawaii hospital here, then them becoming the leaders for their health system, moving it out to the medical surgical floors in an adopted bundle. So B is both awakening and breathing trials. So we envisioned it looking at your PRNs, stopping your PRNs if they don't need benzodiazepines or Benadryl or things like that, having our respiratory therapist colleagues doing the incentive spirometry, if it's still evidence-based or not, but having that same conceptual approach rolled out to the medical surgical, because they do have deep losses sometimes. But that would be a good thing. If we got good enough that they have losses, that would be, I guess, good. But then, yes, rolling it out to different places in the hospital.
Thank you, Michele. Yo, this is Julie Barr. She's the first author on the PAD guidelines. Thank you, Julie. That's neat. So for the people in the back of the room who may not have heard, they just basically said, we're not satisfied with the amount of mobility we got in the unit. It's going to have to get better on the floor. And that's very progressive thinking, because Heidi will tell you that despite all of her aggressive work in the unit, when they go to the floor, a lot of times it goes the opposite direction.
Yeah. Correct. Yeah. There was a study at LDS Medical Center. Which one of them published this one? I think it was Mona Hopkins. No, I think it was Ramona Hopkins. So actually, LDS Medical Center, that has the most aggressive early mobility program of any place, anywhere, really and truly. Their protocol is their mechanically ventilated patients need to walk 200 feet before they are extubated. They found that their patients, even though they have been doing this since the year, 2000, so for 16 years, they've been mobilizing that aggressively, their patients in the ICU. They found the patients went out to the floor and did not much. And they wrote that up in an entire study. So if you feel like you're alone in that experience, chances are you really are not. They found that 50% of their ICU patients who had walked in the ICU spent that first day out on the floor in bed. Most of them did less than they had done when they were in the ICU. Yep.
Please, next question.
Hi, I'm Dina LaRue. I'm the medical director at Tucson VA for the ICU. I just wondered if somebody could comment on dealing with patients who have agitated delirium in addition to a background of PTSD. Because I end up getting a lot of those kinds of patients, all ages. I'm getting young patients who are fresh out of Afghanistan and Iraq, and I'm getting the older, I still have World War II vets that still come in. And it's a problem, and also those who have dementia. And then I'm trying to deal with the agitated delirium and trying to keep them awake and getting them moving and cooperative. So are there tricks that anybody has for that and keeping them out of restraints?
Yeah, I have a patient. I work at the VA as well. I'm 7/8 VA at the Nashville VA, and we're moving our ICU Liberation program. We were one of the two. Julie Barr and Palo Alto were the other VA in the ICU Liberation program. So there were two VAs in ICU Liberation, and we should talk more later, okay? Because I want you to talk to Michael and Kelly and Margaret, the other people who ran this at our center, and we're about to move ICU Liberation out throughout our VISN. I stepped out a few minutes ago to have a meeting with Tom Wallace. I don't know if Tom's still in here or not, but we're going to spread it to Louisville, Lexington, Memphis, and Mountain Home, which is all of our VISN ICUs. So this is happening. Now, I had a patient a couple months ago, a veteran with PTSD on the blower, profound hyperactive delirium and PTSD, thought we were coming after him, imagine being tied down. So on the ventilator, I use a lot more dexmedetomidine than I do anything else for a patient like that. No respiratory suppression, and you're going to get enough sedation that it will take the edge off of this patient. We titrate that up as high as we need to go without it causing a profound bradycardia problem. So I would say on the ventilator, I would use more in the way of either a dex only or a dex narcotic combo if there's pain involved. And if we don't know if there's pain involved, then I would start with analgo sedation, made popular by Thomas Strom. No sedation / analgo sedation. I know those are not the same thing, but my point is that you can extend either less is more, or if I'm going to layer one thing on top that I need, make sure I cover pain. If there's no pain, then maybe an alpha-2 agonist. We're studying propofol versus alpha-2 agonist right now in a randomized controlled trial. It's called MENS-2. MENS-1 was alpha-2 agonist versus GABAergic drugs with benzos. We now have 1,500 patients worth of a comparison between benzos and alpha-2 agonists, and the benzos lose that pretty profoundly. So now we're doing alpha-2 agonists versus the GABAergic propofol in an NIH-sponsored investigation, not industry-sponsored, and we are about 300 people into that study. Is that right, Brenda?
About 250.
250? Mm-hmm. So we've got another 150-ish to go in that study. But the reason I choose dex for this patient is lack of respiratory suppression. I want to get him off the ventilator. So that's the reason why for there. Now, if not on a ventilator, or maybe bradycardia is an issue, or maybe the pharmacy doesn't like the cost of dex, although it's gone to generic, then I use antipsychotics. But I wanted to explain this. We don't know if antipsychotics reduce delirium. We really don't know that. We know that they can provide sedative effect, though. And so we give IV and or PO antipsychotics a lot of times for sedative effect in a hyperactively delirious patient. I didn't say to treat the delirium. I don't know that. But it will get rid of those positive symptomatology issues that the patient is suffering from, this hyperactive delirium piece of it. And in the name of science and trying to get more data, we have only about 30 people left in our large phase 3 study of IV antipsychotics for delirium. Brenda Pun and the others in the room, Leanne Boehm, has done a lot with this investigation, helping us to design it and organize it. Leanne Boehm is a PhD nurse at Vanderbilt now and at the VA as well, along with Brenda with her DNP, both on our team. So we have a multi-center interprofessional study going on with the ABCDEFs for all patients, and then randomizing to Haldol, Ziprasidone, or placebo, and we'll get you more information on that later. That's the way I approach those patients. Yes.
In our VISN, we're in VISN 21 in California. We're working with the other hospitals in our VISN to standardize all the A through F bundle metrics as well and to get them into our EHR. I know VAs haven't standardized their EHR, and I don't know what you use. We use ICs in our VISN. The other thing is we have the same population, right? 30% incidence of active psychiatric illness. So one of the things that's been very helpful is making sure that we're restarting those patients who are on psychotropic medications before they got sick as soon as possible, and getting the psychiatrists more actively involved. But not so long ago, when we would ask the psychiatrist for help with a severely agitated patient, they would come up and they would say, well, the patient's too sleepy, I can't evaluate them, call us back when they're extubated. But now that we have more of a culture of light sedation where they can actually interact with the patient, they're much more forthcoming, much more helpful, and they have been truly an asset in dealing with that very problematic group of patients.
Thank you for that, Julie. We'll go to the last question, but first I wanted to make sure, and Matt, sorry I'm going to introduce you here, don't want to embarrass you, but Matt Aldrich, sitting over here, raised his hand, is the new leader of ICU, who's one of the new leaders of ICU Liberation, who hasn't been introduced today. So I just want to make sure that he was made known to you as one of the other people not on the panel, et cetera, who's going to be helping us to lead this from UCSF as one of the physician leaders. So please, last question.
Hi, I'm Amy. I'm from Rush University in Chicago. I'm a bedside champion for ABCDEF, and I'm in a neuro ICU strokes and spines exclusively, and we're having a really big problem with buy-in because with the baseline mental changes with assessing delirium. So I was wondering if anybody had any helpful tips to try to suss that out.
Go for it. Thank you for speaking up, please. We have plenty of experts here to help address that.
So neuro, obviously very special population. For most of us, it's the 1%, not the 99%. I know a lot of our sites, we get this question a lot. A lot of it has to come down to explaining, and Wes does it very nicely, but there's a lot of resources on the ICU Delirium.org website as well. The fact that you can have the secondary form of brain injury and sharing that information that it is possible to get delirium superimposed. We always say delirium superimposed on dementia, delirium superimposed on other traumatic brain injuries as well. So a lot of education needs to be provided in terms of how to perform the CAM ICU, that it can be performed in that type of population. But you do need the buy-in in the physicians, because with the neurosurgeons or neurologists that you're working on too, that everybody's on that same page so that the staff gets the consistent message. Is that what you found as well? Yeah. Because there's a lot of naysayers that don't think that it could happen in that population. So arming yourself with the data and the research that's been conducted would be very helpful.
We created a letter about neurosurgical patients, neurointensive care patients for the ICU Liberation Collaborative. And I don't know if maybe Diane Byram can share that with you. So Diane, raise your hand up here. If anybody in here who wants to know, wants to receive the letter about what we taught the rest of the collaborative about how to assess delirium and neurocritically ill patients, come on up to Diane, give her your email address, and she can get that letter created to you. It's an evidence-based letter. And actually, I'll let you know that we're taking that letter and trying to create a paper about it so that this will be present in the peer-reviewed literature. But the bottom line is that there are data to help you because it's a very tough topic. Diane will send you the letter.
And you're not alone. As soon as you said you're from a neuro ICU, I knew what your question was.
Okay, we're out of time, and we thank everybody for their attention.